Let's talk about some of the newer treatments that we've got in asthma. Since there are different types that you say, we use the word phenotype. It's sort of a new word to me. What does that mean, phenotype?
Kind of a new word in asthma. We're learning there's different phenotypes. So phenotype is, the best way to think of that is like a face, okay? We all have different faces, different genetic makeup, but there's some environmental factors that influence that face. And in our case, a cruel gene that made our hair fall out. But all
that doesn't cause asthma, does
it? Lots of other things, but not asthma. So if we know your phenotype, that may influence, well, I may use this medicine, or you might respond better to this and not that. So we're getting a feel for phenotypes, but it's not something your doctor will necessarily talk to you about yet. But it's a very active area in asthma, and we're looking at phenotypes, trying to find out what makes up a phenotype, what inflammatory pathway drives that, so we can pick better medicines for you as an individual rather than as the whole population of asthmatics.
Do we have specific medicines for specific inflammatory pathways you mentioned?
Yeah, so in the past we've had anti-inflammatory medicines that were rather non-specific, like that foundation, that cornerstone drug, the inhaled steroid. It works, but it just kind of blanketly hits a number of things. Well, now we have anti-inflammatory medicines or biologics, monoclonal antibodies, which target unique aspects of the immune system.
Give me an example of one. Let's talk about the inflammation. That means there's different cells causing problems. What is one of those cells that you think of that causes problems and inflammation?
Yeah, so, well, the eosinophil would be one of the main cells, but it's kind of interesting. We see a lot of stuff. We see lymphocytes, neutrophils, epithelial cells that are not just epithelial cells. They do a lot of things to promote this inflammation and symptoms as well.
So we've got newer medicines that could go after the different type of cell types. For instance, the eosinophil. What are some medicines that are available? If somebody's got asthma, and that means they're on a reliever and a controller, but their asthma is still causing trouble, what do you do about the eosinophil inflammation?
Yeah, so that's that kind of severe persistent asthmatic. It's a minimal part of the population, but they are the ones that are in your office the most, in the emergency room the most, the hospital the most, use up healthcare dollars for asthma therapy. And we've not had great therapies. We always gave them oral prednisone, but it just didn't always work. So now we know the eosinophil, and we know some of those patients have elevated eosinophil levels. And there are two drugs we use. Both of them, though, focus on IL-5, which is important in recruiting and promoting eosinophilic inflammation. So that monoclonal antibody will bind to that and remove that drive for that eosinophilic inflammation.
So if we can take away the eosinophil, we take away part of the inflammation, it makes the lungs less twitchy, less swollen, less difficult, and the person with severe persistent asthma may have a good chance of getting better.
Absolutely.
So these new medicines that are against IL-5, we said, and the IL-5 brings on eosinophils?
Yes.
So how do we give those medicines? Are they usually by shot? Or
one of them is by shot, and another one is intravenously. There's some nuances to the two, and patients make individual decisions, but either one of those would be a good choice for that eosinophilic inflammation.
So we have to get a blood count looking for eosinophils or sputum examination to find that out.
Sure.